So we're told that more Ghanaian youth are contracting HIV/AIDS, and this was contained in a new survey conducted by the Ghana AIDS Commission. And I've got the acting programs manager for the National AIDS Control Program joining me here on the show, Dr. Stephen A.C. Addo. Good morning. Thanks for your time.
Good morning. Good morning to your audience.
Yeah. So I thought we're doing well with HIV/AIDS as a country.
To a very large extent, we're doing well because the general prevalence dropped from the previous year. That is among pregnant women who are attending antenatal. This is the HIV Sentinel survey, which is conducted annually.
Okay.
We have been doing this for the past 23 years. And every year we check what the trends are. Last year, 2013, the figure...
Last 2 years?
Last 2 years, because usually you publish in the ensuing year.
Oh, okay.
So this is for 2014.
Okay.
So in 2013, the figure was 1.9. Prior to that, it was 2.1. It stayed at 2.1. And then this year, it dropped to 1.6. So on the whole, generally, there is a decline. If you take the regions, we notice increases in 5 regions, and then 3 drops in 3 regions, and then Western region remained the same. Eastern region is still the region leading.
Eastern region.
With the highest prevalence, followed by the Greater Accra region, and then the Ashanti region.
Okay.
And then it continues with Brong Ahafo, and then Western, and comes to Volta region, and then continues with Upper East, and then Central, and then Western, Upper West, before the Northern region. The Northern region is the region with the lowest prevalence.
Okay, which
now,
is, do we?
It's 0.6.
Okay.
It was from 0.8, so percent.
Okay.
Right.
So when we say Eastern is still leading,
it's 3.7.
Has the figure come down though?
The good thing is that it stayed the same. It was the same the previous year, 3.7, and they have maintained it. And it was because, you know, sometimes you have increases in some of the sites and then decreases in some of the sites, so it balances out. But we noticed that there were some regions that has increased, like Greater Accra, for instance, is one of the regions where we noticed an increase. We also noticed an increase in Brong Ahafo. Okay. And then we also noticed an increase in Upper East and then some Central region. You know, but as I said, Western region dropped. Ashanti dropped, though Ashanti is the 3rd. It dropped in prevalence. Okay. And the Northern region dropped as well, and Upper West also dropped. So that is the picture. However, when you take the age groups, you know, we find this prevalence amongst pregnant women who are attending antenatal care services between 15 and 49 years.
15 and 49.
9 years. And 15 to 19, 20 to 24. Now we put these 2 groups together. They are considered as they are the youth, in fact, if you look at it. Despite the fact that the highest prevalence was recorded in the 30 to 35 year group. We should note that the highest prevalence was recorded in the 30 to 35 year group.
30 to 35
year group. Now, if you take the between, let's say, 25 to, let's say, 40, that's where a lot of the cases are. But when you take the youth between 15 to 24, which we use as the proxy of recent infections, because if you are 15 years and you get pregnant, it's possible you've now started. Right, and if there are recorded cases, then we are concerned. And we noticed that for the past 2 years, within the age group 15 to 19, the infection is increasing. It was from 0.7, it's going to 0.8. This year, 2014, it was 0.8, from 7 to 0.8. And this is a continuing trend. When you take the age group from 20 to 24, we noticed an increase this year in 2014. When you put the 2 together, which is 15 to 24, between 2013 and 2014, there was a 50% rise.
Wow.
From 1.2% to about
That's a lot.
to 1.8. Now, the value to all of this, I mean, there are different ways of generating these results. But for service providers and for stakeholders who may be involved in wanting to know where the problems are so that we prioritize, this is where this data, the value of this data.
So what is accounting for this?
Well, it could be a lot of factors. This study tells us what the situation is.
Okay.
So we need to do further checks to see what is happening in that group. Let me state that if you take overall all the age groups, that group recorded the lowest prevalence overall.
Okay.
Except that the good thing about this study is it looks at trend as well. So even though they recorded the lowest, in terms of trend, it's increasing. And we don't know what is going to happen. You know, the whole idea of HIV prevention, education, and all that, treatment, and so on and so forth, has gone on for a while. This time we're prioritizing with prevention of mother-to-child transmission, and putting people on treatment and all that.
Was it India or one of those countries I was hearing on the BBC that has eliminated completely? And I was thinking Ghana.
It's Cuba. Ghana, you know, to say you've eliminated your mother-to-child transmission must be less than 5%. We are currently doing around 7-8%.
Okay, we're still
a little effort, we should be able to get below. So in terms of the reasons, as you asked me, you know, we were doing this prevention education, general and all that over time. That we're not doing actively so much now. We're focusing on the mothers, pregnant women, and prevention to, you know, baby and all that. So I think we need to continue. You see, HIV is such that it doesn't go away. All conditions will come and go, like Ebola and all the HIV, there's no cure. So we need to at least retain some of the things we do. If you even take mother-to-child transmission, elimination, there are 4-pronged strategies. And the first one is making sure that there's primary prevention. So in the general population and children and women in reproductive age group, we should make sure they are negative. And that is where the youth come in. And so we have to still continue to target them with some prevention, education, and all that. They need to stick to the ABCs, to use condoms where they have to, because I think the general public awareness may be reducing. And these are young people who are now growing, and those who benefited are now older.
Is it your funds that's been cut down so that we don't see the campaigns as visibly as we would, or we did?
So when you analyze in time, you need to be able to decide that if you have a certain limited amount of funding, you have to prioritize the funding. And so resources will not come for everything at the same time, every time in the year or in the number of years. So whatever is available to you, you need to analyze and say that, okay, all these are important, but what to give us the greatest impact at any point in time, and therefore money has to be prioritized, reprioritized to these areas. So when you even take the elimination of mother-to-child, all the 4 prongs, you've noticed that development partners and the global, you know, stakeholders will be focusing on aspects. Now, but I think in principle, that shouldn't let us overlook the other aspects, except that the magnitude of carrying out the other aspects will be relatively lower than what we consider to be critical, you know, at any point in time. So we need to go back. There are school health programs, you know, for HIV prevention. We need to once again reactivate, you know, those programs. There are some things we need to do to target out-of-school youth, people who are out of school. There are quite a lot of these children, young people who are not in school. They are involved in some little trade here and there, some of the potters and so on and so forth. We need to see how we can target all of them, because it means that if they are getting pregnant and they're getting positive, they're not using the prevention strategies, and we need to bring it back to focus. But you know, the people in school are already target. You can reach them. Yeah. Let's
go back to how many people were involved in this survey.
Yes, in fact, we analyze over 16,000 samples across, and in about 40 sentinel sites. There are 69 ANC clinics that are involved in this, geographically spread in the whole country. And we ensure that you pick from urban sites and then rural to give a good picture. All right. So out of these 40, we analyze samples from 39. And it's actually every region has an average of about 4. You may have one that has 5, but every region has an average of 4. So that brings it to about 40. There are 23 urban sites and then 17 rural sites. Yeah, so once you take the data, we do some analysis, and then we do external quality assurance. Because every test that is conducted at the site is confirmed again at the national level. And then we even, at the national level, take samples, and Noguchi Memorial Institute for Medical Research has to do external quality assurance to validate our results, to check whether what we said was positive was truly positive, what was negative was truly positive. And the results came very, confirmed.
I am worried. I am very worried because recently we've been asking a lot of people to donate blood. And we know that if you are HIV infected, there's no way we can use your blood. And you give a number, an age group between 30 and 35. That
they were the highest. Yeah.
They were the highest, and that's even more worrying, because a lot of people who fall in this group will be young people who are married, young married people, or people who are beginning life, if you like. I mean, everything is getting on now. And if they have AIDS, then we're in trouble.
Okay, I think we should separate the two terminologies.
If they have HIV AIDS,
yes.
That's the virus.
Okay, so if they have HIV, they don't necessarily have AIDS. Okay, but I'm sure the effects for you comes to the same. But even don't limit yourself to the 30 to 35. Add the 15 to the 35. Because when you look at it, assuming you even exclude the 15 to 19, from at least 20 to 35, these are the majority. And these are the people who donate blood. Right, so I agree with you. But in Ghana, their policies, our blood donation system is quite proof to a certain extent of people, we transmitting infections to people. In actual fact, the blood is thoroughly screened. And before anybody is given blood, we take it through certain processes. And nobody is supposed to receive potential infected blood. I mean, in Ghana now.
My worry is that then we can't make use of them.
Yes, except that once we take it and we notice that there's a problem, we discard it. And that is also wastage, isn't it?
Yeah.
But there's also the issue of window period. We always talk about window period in HIV. If I have HIV and I come into contact with you through sex and there's any exposure, and for instance, I give you the virus, we will not be able to detect it within a few weeks. That's what is called the window period. There is a period that it will take before we detect it in your body. And that is the danger, and that is why the issue of blood transfusion is of great concern. And so we're very, very critical. We will not transfuse. And the blood transfusion services have various methods of going about this. They will screen it to start with. If it's negative, they will store it. Over time, if they want to now transfuse, they have to check again. Those are all.
What's the time within which, if I have the virus, you should see when you do a test?
Yes, so we talk about a 6-week period. And it's up to 6 to 12 weeks. 6 to 12 weeks. So the earliest we can pick 6 weeks. But the studies have shown that some people we detected it within 2 weeks. Right. As we move forward, in fact, this detection is not detecting the virus itself. It's detecting the body's response to the virus. So once the virus gets into the body, it generates antibodies, like the soldiers who fight the virus. And that is what we pick. And that's what we do in the national when we use the test. That's what we pick. But I'm sure as we move forward, we're now getting equipment that will enable us to pick the virus directly, which means that but you see, even that, the virus has to multiply to a certain quantity before you pick it. That will help us improve the time and shorten the time for detecting. But in the meantime, the current methods, to a very large extent, in fact, assures us of free blood transfusion, free of the virus. Yeah. But it's important that we bear this in mind. because in the program has been working with the transfusion services to create what we call the safe cohort. The safe cohort is a group of people who are considered to have very low risk for HIV and who constitute the blood donors for the country as they go on. So we follow those people closely and make sure that they're not involved in things that will lead to they getting HIV and all that. So that anytime we pick from them, we know that they're safe. But how many people will you get? You have to rely on the volunteers, voluntary donors, you and I. And so everybody has to be targeted with prevention education so that we all stay negative. If I'm looking at this figure, 1.6, and over the past 10 years is declining, hopefully we should drop further if we intensify our efforts. It means that even the general population, we should see some reductions, hopefully lower than the antenatal, because these are a group of people who are pregnant. It means they had unprotected sex. If you add the children who are not having sex, if you add older people who are retired from sex, maybe in quotes, if you take other people who will not be pregnant, it will dilute the effect. So the overall national prevalence perhaps should be lower than the ANC prevalence. What it means is that as a country, all the interventions targeted at different groups should be sustained, including high-risk groups like female sex workers and men who have sex with men. We've been on the social media, people are discussing the gay issues and all that. But the one group that will have a higher risk, and we need to target all of them because they're in the general population and they can transmit because the interactions are complex.
But you know, if it's a man having sex with a man, how do you protect yourself then? The
same thing if you use a condom. All right. The protection is condom. The risk is higher because compared to having a man and a female. But the barrier becomes condoms. There are also other new mechanisms, using drugs, when we call it pre-exposure prophylaxis. Because of the potential risk, you give it to the person before they have sex.
Okay.
And then that will reduce the risk of transmitting. Right.
That will reduce the risk.
The risk, but not eliminate it totally. The studies have shown. As a country, we've not adopted that policy yet.
Okay.
We only give what we call post-exposure prophylaxis. And that is for people, health workers, who maybe are taking care of a patient, they get exposed. And we give it to them very immediately so that we prevent the transmission.
So it's not available for ordinary?
No, it's only available for rape survivors. Apart from health workers, rape survivors. But as a country, if we decide to push it for the whole population, there will be a problem. We believe it can be abused. We can consider it for very high-risk groups, but it can be abused because we have limited regimen options for the general population. And if people use it this way, then later when they perhaps have the condition and you give them the same drugs, they may have been resistance and so on and so forth. So we are cautious as a country because every now and then even we need resources to cover all the clients who are on therapy. So you actually strike cautiously. But when situations get better, I'm sure we should be able to take on board.
Are we looking at a country, for instance, that has done what we are doing or has been successful at it?
In terms of what?
In terms of either the post...
The pre and post.
The pre and post.
Yeah, countries have done it and they've been successful at it. The Western nations, they've done it.
But it's not widely available so that anybody can have access to it?
Once it's a policy, it's to be available. I know policy goes with commitment. So if we say that it should happen in Ghana, we need to support it with the resources. Okay, so if you cannot provide the resources, then there's a problem. You need to be able to manage it. At this stage, not. But the world is ready. It's one of the interventions that have been found to be very useful because treatment is preventive. In fact, it's based on that in our new guidelines, our problem is more with the general population, heterosexual transmission, even with men, man to woman, the majority. So we are considering that now if a person is HIV positive and the spouse is negative, you immediately start the treatment to protect your spouse. In the past, you need to meet the criteria the certain criteria before. That is also preventive for the spouse. It's the same principle that will be applied to, let's say, men who have sex with men over time. We're currently working hard to estimate the sizes of those groups to be able to find methods of engaging them, because you need to be able to know them, engage them, and then we know the numbers, we can plan for them, and so that we can be able to provide these services, for them. Once we're able to do that, it's easier. But when you just start it generally, every other person will abuse it. When who want to have sex with a woman, and I think I'm not afraid of HIV, I just go and take it.
Yeah.
Some of these drugs, it's not easy to take. There are side effects and all that. But you notice that so far, our prevention education for the whole country has helped. To imagine that we are dropping, okay, we're moving. This is the second consecutive time that we've dropped below 2%. And it's the first in history that we had this lowest figure. If we continue to sustain our efforts, making sure that at least those who need a drug, they get, eliminate mother-to-child transmission, work together within the antenatal care, provide prevention education, making sure that the youth, general population, everybody, they are taking the measures. They do not forget that HIV is still real. We should be able to push it down further.
Let's talk about the 15
to 19.
15 to 19.
Yeah.
When you talk 15, then you'll be talking about girls.
Girls.
Because you realize when they're pregnant.
Exactly. How about those who don't get pregnant?
What is it that parents are not doing, really? Because if a 15-year-old is pregnant, it can only be through sex.
Yes,
and unprotected sex.
It can't be by any special means. It's only one person we know and believe got pregnant through the influence of the Holy Spirit. So clearly, and in the dissemination, somebody raised the question that they've even noticed that younger children, younger girls, are getting pregnant less than 15. Well, there are a lot of factors, the social factors, social family systems breaking down, upbringing is an issue, people are dropping out, there are socioeconomic challenges. All these are factors. At this level, what is the level of sex education? In fact, we've been talking about this in families. How many parents speak to their adolescents and young people about sex? This is something that we don't want to talk about. It's a societal issue, and therefore we all shy away and hope that somehow it doesn't happen. But it's happening when you monitor the trends. People who get pregnant, teenage pregnancies, those who have to take the BEC and all that, it means that something is going wrong. It's a breakdown in family system. At least if the families are together, parents will monitor. But where perhaps there's a breakdown, then these children are on their own. And then we find many people also abusing people. There's an evolving trend, a Western social behavior. And perhaps this is also because we are developing as a country, lower middle income exposure to the media. All these things have a role to play. And we need to find ways to intervene generally.
Are people using condoms more today?
Not. We are not happy at all. Because currently one of the things we are discussing together as stakeholders is how to improve condom use. Use is very low. Condom utilization is low. We had some challenges with availability. Perhaps that may have contributed, but this year is going to get better, next year better, and we are
in terms of the availability of condoms.
Yes, and we are going to challenge ourselves to ensure that as many people as possible who need it out there get it. Except that, you see, if you promote condoms within the health system, well, it's because people are sick, that's why they come. You have to do a lot of social, community-based promotion, and we need to improve that. There are, for instance, if you are taking the youth, there's been a debate as to whether we should promote condom use in schools and all that. Yeah, PTAs will not allow, because the point is that if you do that, it means you're encouraging them to have sex. But whether we do that or not, they are having sex. So perhaps we need to target the social places that they play, where they go, and make sure that they're available there. We need to make it available in the tourism industry, in hotels and all that. So that sometimes when people have not even dreamt to have sex, on the spell of the moment they want to have, and something is available. Condoms should be available if you want to use it. And then in the workplaces. And I noticed that still people will patronize it because you place condoms here even in Joy FM. I think if you have a place, a washroom, and come the following day, it will be missing. People would have taken it. Except that everybody feels shy to go to the, let's say, counter and say, I want condoms. And we hear stories about people who, when they wanted condoms, and somebody came all of a sudden and they changed the condom to something else because they didn't want the other person to know that. You know. So we also have to deal with the mindset. The fact that if I have condoms on me, I'm promiscuous. Okay, I have no choice. So wherever I go, I must have it because of the job I do.
But it's not free. I mean, I thought we would get to a point where it will be free, so you can just pick it up anywhere.
Not everything which is free has value. People don't necessarily place value on everything which is free. That's why it doesn't have to be free also. Because we've noticed that when things are free, people take it for granted. But if you take the cost of condoms, it's so minimal. Everybody can afford. In fact, some people go to the store buy the expensive ones, you know, the market. There's very special ones and, you know, flavor and all that. But what is provided for HIV prevention and within the family health division is quite basic and very cheap.
So there's no difference?
It's very cheap, no. It's very cheap. But so that the others may come with some additional things that make it more expensive. If you do that, then you can't sell it. You can't, and it has to be paid for. It's possible to make it free, but as it is now, it's almost free. So I think cost is not a barrier. What we need to do is to make it available everywhere. And you can be able to, people will get access and they will utilize it.
I've got 3 questions. Because of time, I don't know how I'll do this. Are we learning about HIV in schools? As in, is it part of the curricula? We haven't been able to do this.
Yes, we are learning. Through the SHEP School Health HIV program, there have been within some of the topics, social studies, to talk about HIV. That is reinforced with occasional specific seminars. But I think we need to go back and see and discuss the details to what extent this education is provided in the schools. But it stops short of just the information. But you know, knowledge has to be linked with behavior. So when you give all this knowledge, how should this child behave when he or she finds himself in a situation of vulnerability?
And that's tricky because that's when the parents are not allowing the use of condoms. And we need to look at it. Are the churches allowing you?
Now the churches are allowing us. Because when we tell them that the people who come to our hospitals with pregnancy when they are not supposed to are the church members, I can categorize them by the church group denominations. I can categorize HIV people by denominations. And they got it because they had unprotected sex. So for us to pretend that the people in the church are not engaging in risky behavior, it's not fair. So through our engagement with some of the faith-based organizations, they are accepting HIV information now. In the past, it is a no-go area to come and talk about condoms in the church. Now it's been accepted, but there's still a barrier. Some churches will not allow you to use their premise to talk about HIV. But thankfully, working with even health service providers who are church members, they've been able to engage their women's groups, sometimes men's groups. I've had occasion to interact with some of the Muslim groups and all that, and with education. So we believe that continuous engagement should make a difference. Even we've helped some churches to set up testing units within the church, where people can go on a Sunday, for instance, and check their status.
I want to ask about your biggest challenge, but I want to also talk about why is it that when I want to test,
you need to go to a facility?
I can understand that, but how about the counseling? I mean, that session can be too long, and
we've changed it.
Really? So how is it now?
Now it's pretty fast. We do now testing and counseling. In the past, we spend a lot more time counseling because it's a process. Now at this stage as a country, we give you just basic information that we are going to test you. This is what will be the outcome when it is this is what you do. Then we test you. Then rather when we have done the test, we spend more time to talk to you. in the setting of in ANC setting, pregnant women, they give general information for everybody who is attending antenatal care. They will spend to general everything. Then when you are in the cubicle, your sample is taken. If you decide to opt out, that is fine.
When you're pregnant?
Yes.
I thought it was compulsory because you know they have your sample before they even tell you what kind of test they're carrying out on you.
Well, make it bolu compulsory, but it's not compulsory. You can opt out. You can say that no, you don't want it. But the good thing is that acceptance rate is very high, almost 100%. All right, so we are offering it. So as much as possible, we are just offering the test. We don't spend too much time now going to town, you know, and all the things.
Okay.
So the process is pretty fast now.
How long does it take
it will
for
take
me
you
to
within
know
10 minutes.
if I have it or not?
Yes, within 10 minutes.
But do I have to come and check
minutes.
again? Do you have to confirm again?
We will no. We will only do that if, for instance, when I assessed you, I realized that your risk profile warrants that we repeat it. If you told me that you had certain unprotected sex, you are not sure of the person you had sex with, I checked today, you wouldn't be positive if you were negative. So once you are negative, I said, okay, let's give ourselves 6 weeks because of the window period, or 12 weeks, and then you come back and we repeat. That is to that extent alone. But if I check, then you have never had sex in the past 1 year, and I check today, or 6 months, and you are negative. Okay. I wouldn't ask you to come necessarily. So I would just rather say that protect, make sure that the next behavior is not risky.
Okay. So unless you're not telling your doctor the entire truth.
Unless you're not telling the doctor.
But there are some husbands who think that because their wives have gone through the tests whilst they were pregnant,
and they
could not be positive.
It's not true. In fact, going forward this year and beyond, we're going to intensify couple testing. Because sometimes even the men who give it to their spouses do not come to the hospital. We may pick a woman who is positive, and it's possible it's the man who gave it to the woman. But because a man doesn't get pregnant and come to hospital, it must be something else that will bring a man to a hospital. We don't get to reach out to them. We're going to see how best we will reach out to these men and improve their testing. Because in our program, we noticed that testing for males is minimal.
Yeah.
Now, a man is not automatic because two people can still be married. One can be positive and the other can be negative.
Really? So the woman could be positive, could be negative, and the man
could be positive. Oh. The woman could be negative and the man could be positive. That's what we call discordant, serodiscordant couples, and they're quite a number, right? Because it doesn't take, let's say, one episode of sex for a person to transmit, and a lot of other factors could come in. So that's why everybody independently should be checked. Except that we should link it to also behavior. If somebody says that a person believes that I've never had sex for all my life, then we assume that perhaps the person cannot be positive. But sometimes you check and it happens. The same people come to the gynae ward and they said they don't even have a boyfriend, but you check and they are pregnant. So we will not take chances.
Yeah.
And we'll give everybody the opportunity. And sometimes when you check, then people are now remembering, okay, maybe something happened in the past. But at that stage, they don't have a problem.
Yeah. So finally, let's talk about some of your challenges at the AIDS program.
Yes, I think the main challenge, we have realized that now that even the prevalence is dropping, everybody is likely to treat Ghana as now the problem is reducing. So if there's money, they will not push in that as much as possible. But we're happy to state that we continue to talk to our partners, and hopefully they are assuring us of resources. The other thing is that because we are now lower middle income, there is a greater pressure on the government to take care of all HIV needs as much as possible. Now the developed partners are saying take care of a proportion. All right, but I'm sure as we are moving forward, they will increasingly offload a lot of their burden of resources, amount of money they give to the government. And you know that is the same budget for everything. Yeah. So funding is a challenge. So as we speak now, there are gaps, for instance, in the funding of our programs. The other challenge has to do with human resource. You will notice that the same human resource is taking care of everybody. And there's a high attrition of human resource. There's limitation of recruitment also. And so the same person who is doing malaria work, TB, doing all the other thing has to also focus on HIV, and it's not so easy. The other thing is infrastructure. Some of the remote areas still don't have immediate services. We need to roll out to this. It's linked to human resource plus building of structures or providing the infrastructure to do this. We need to be able to address all these. If we're able to address these, we'll be successful. The last has to do with the mechanisms for distributing the commodities. First of all, the money for it, and then when it comes to country, where to send it to the facilities, how fast that can happen is one of our challenges we're trying to improve this year. You know, we experienced the CMS fire, so our central medical store is
because I was
gone.
going to ask, did the central medical
so
stores affect you?
It's an effect. It has had an effect. It means regions have to hold more commodities. The regional stores are not also that huge. So we need to find more money to expand. It means that facilities must create bigger space to hold more commodities. All that is financial.
Yeah.
All right. So apart from the efforts to refurbish, or let's say rebuild a new central medical store, we have to decentralize as much as possible.
Are you beginning to get your stocks back? I mean,
Yes. We are gradually emerging, from the crisis.
But are you able to internally generate funds?
No, HIV, you can't generate funds. In fact, in the past, people were paying 5 cedi service fee. It's been taken away. But if you are in health insurance, you shouldn't pay that amount of money.
Do we have enough antiretroviral?
Yes, for now.
Okay.
We have.
So
we are doing now a scheduled delivery to regions.
Okay.
Yes.
All right. So where can people do the tests?
Anywhere. When you go to any health facility, you can do the test. We're still encouraging people to walk and do the test in any facility.
Are people willingly doing that?
I think over time, people have assumed, they've been complacent, that HIV is not a big deal again, and so people are not willingly doing that. So the health workers should offer to anybody who even visits the hospital. But we encourage people to walk in and then want to know their status.
Okay.
And this year and beyond, we will be seen to reintroduce a certain outreach testing where we come and set up in Joy FM one morning and say everybody who is willing, whosoever may come, we want to know your status.
Yeah.
And the motivation is that you are likely to be negative because only 1.6% among pregnant women, if you use the whole country, is less than 2. If you take 100 people, only 2. You may be a part of the 98, so come.
Okay.
The other motivation is that nobody should die from HIV or AIDS in Ghana today. You can die from other causes because there is treatment.
Yeah.
So the earlier we know, the better. So we can link you to treatment.
Yeah.
And you can survive and continue to perform your roles and to contribute to this country.
Sure. We're waiting for you to come and set up. I'll convince all my colleagues here to come and do
Beautiful.
the test.
To start, first of all, with you accepting a workplace program. If you have a policy, you need to have a workplace program policy. And then in that policy, we can do education, provide condoms, do periodic testing. You can offer it to your clients and customers when they come around.
Okay. So we can together do one and open it up even for the general public to come by and come and do a test. That would be good. Yeah. But thank you so much for your time this morning. Really enjoyed it.
Thanks very much for having me. Thank you.
So Dr. Stephen Ayisiado is the Acting Programs Manager, National AIDS Control Program. Why don't we all get testing? And even though you may not see the campaigns on your screens or on your radio, as we often would in the past, please, AIDS is still real. Let's take it serious and let's get testing now. Stay on. We've got AM Talk coming your way. Okay.